Welcome to Inside 340B Report, an insightful conversation between 340B Report's editorial team on the key issues affecting the 340B drug discount program, the nation's second largest government drug program.
Hey everyone, and welcome to the latest episode of Inside 340B Report. I'm Will Newton, and I'm an associate editor and senior writer at 340B Report, and I'm joined today by my colleague Shannon Young, who is also a 340B Report associate editor and senior writer. And as you can see, our publisher and CEO, Ted Schlafsky, who's usually with us, is off today, but he should be back around for our next podcast. So we got a ton to cover as usual today, but very quickly before we start, just wanted to let our listeners know that we are offering a special 25% discount to 340B Report for first-time subscribers. You can go to the subscribe tab at 340breport.com and use the special coupon code podcast25 to take advantage of the discount. And so I would strongly recommend all of our listeners do that. Also want to very quickly encourage everyone to check out 340B Report's other podcast, 340B 360. It's hosted by Anna Mangum, and it showcases leaders from 340B Report's valued sponsor companies and the crucial role that they play in the 340B ecosystem.
Yeah, so we're really excited to dive in today. As Will said, there's been a ton that's been going on since we last had our episode. So some of the things we're going to discuss today, we're going to provide an update on the latest in the 340B rebate saga, including the latest legal developments and what's going on with HHS's proposed guidance. We're also going to discuss recent developments in the Trump administration's efforts to lower prescription drug prices through various executive actions. And finally, we'll take a look at what's been happening at the state level. Spoiler alert, additional states have enacted 340B contract pharmacy access and reporting laws since we last graced your headphones. So Will, I know you've been doing the bulk of the reporting on the 340B rebate fight. Can you give us a recap on where things stand?
Yeah, so we've been doing this podcast for like 8 months now, and I can't remember the last time we had an episode where there wasn't some kind of huge development in this rebate saga that's been going on for a while now. So the two main areas where this is really playing out is one in federal courts and two in some guidance that the U.S. Department of Health and Human Services is preparing. So those are the two main things we're following. And the first important one is the federal courts. So as many of our listeners remember, last year, 5 different drug companies, Johnson & Johnson, Eli Lilly, Sanofi, Bristol Myers Squibb, and Novartis, all approached HRSA, the agency that oversees the 340B program, and said that they plan to convert upfront 340B discounts to a post-purchase rebate model. HRSA responded and said that they believe the 340B statute says that drug makers can't implement rebates unless they first get approval from HRSA. And the drug makers disagreed with that and sued HRSA, and those cases went before a federal district judge. So last month, there was the first ruling in a consolidated case involving 4 of those drug makers, BMS, Lilly, Sanofi, and Novartis, as well as the drug industry vendor, Calderos. And the federal district judge there ruled largely in favor of the government and said that drug makers can't unilaterally implement 340B rebate models unless they first have approval from HHS. So it turns out after that ruling that neither the drug manufacturers nor hospitals were entirely satisfied with that, which sort of brings us to where we are now. So several of the drug makers involved in that case appealed the ruling to the DC Circuit Court of Appeals and filed an emergency motion basically arguing that, we need to have the DC Appeals Court rule on this quickly because we have quickly approaching deadlines with the Inflation Reduction Act's Medicare drug price negotiation program, which directly intersects with the 340B program. So the appeals court did grant that motion, and they are going to hear this appeal on an accelerated timeline, which means that oral arguments for the case could take place as soon as early September. That's what the drug makers are pushing for. But, we don't really know for sure when that's going to happen. It hasn't been finalized, but the drug makers are hoping that the appeals court will say that they are allowed to implement rebates regardless of what HHS says. Now, these cases were between the drug industry and the government, right? The drug makers sued HRSA, but there's an intervener in the case, which is the trade group 340B Health, which represents a bunch of hospitals. And so as interveners, 340B Health can represent their own interest, which is the interest of hospitals and providers in the litigation, and they can file briefs, they can, participate in oral arguments and appeal rulings. And so 340B Health has been opposing drug maker rebates and arguing that implementation of them would, significantly harm their ability to serve vulnerable patients. So 340B Health, actually shortly after the drug makers appealed the ruling, they filed their own cross appeal, basically arguing that the federal district court should have gone a step farther and ruled that 340B rebates are categorically prohibited under the 340B statute. So the district judge said, drug makers can't implement rebates without HHS approval. 340B Health is arguing, no, actually the statute says they can't implement rebates, period. So the drug makers responded with another emergency motion saying that the court shouldn't consider 340B Health's motion. So there's, a ton happening there, and a lot remains to be seen sort of how this plays out and whether the appeals court's going to agree with this federal district court. So the other main area where the rebate saga is playing out that I quickly alluded to earlier is in regulation and guidance. So HHS submitted a document called 340B Rebate Guidance to the Office of Management and Budget on June 1st for regulatory review. So this is sort of the final step that any guidance goes through, where this OMB will review the guidance before it officially becomes finalized and public. But during this review, we don't know what the guidance says. We don't also know exactly when it is going to be public. What we do know is that supporters of 340B rebate models, as well as some of the biggest opponents of rebate models, have been meeting with OMB quite a bit to basically try and get a final word and have some sort of influence about what this final HHS guidance looks like on 340B rebates. So what this says will be very important, because as it stands now, HHS gets to decide when and under what conditions 340B rebates are permissible. Though, as I said, with all this litigation and appeal and cross appeal, whether or not HHS has that authority still could change again. So that's sort of where we are right now at the rebate saga.
Yeah, it's really interesting, especially the fact that we don't know what's in this guidance yet. We're probably not going to know for a little bit, but we're seeing all of these meetings happening. And so I think it's going to be really interesting to see how this all plays out and what exactly is in this guidance. But before we continue, let's take a moment to hear from one of our great sponsors.
Compass RX is the premier AI services platform built exclusively for 340B. With our unique blend of pharmacy and AI expertise, we help you maximize your 340B savings by maximizing pharmacy capture rates, putting your team into hyperdrive, and ensuring you aren't leaving any money on the table. Our mission is to unlock the power of AI for 340B. Head to compassrx.com to learn more and see if AI can solve your magic wand problems.
So prescription drug prices have remained a hot topic in Washington, with the White House taking new executive actions and some key administration officials also touting their drug pricing policies on Capitol Hill. So Shannon, can you sort of fill us in on what the latest is there?
Yeah, definitely. So the past couple days, HHS Secretary Robert F. Kennedy Jr. went before the House Energy and Commerce Health Subcommittee, which is a key committee for 340B policy, to discuss President Donald Trump's fiscal year 2026 budget. Now, as you all remember, the president's budget proposal includes a somewhat contentious plan to move oversight of 340B from HRSA, which has overseen the program since 1992 when it was created, to CMS, the Centers for Medicare and Medicaid Services, which notably is the one that's overseeing drug price negotiations under the IRA. So some people think this makes sense. Others have a lot of concerns about it based on CMS's past policies that have affected 340B and drug prices. And so Kennedy went to testify on this budget. It's a pretty typical thing that happens every year. We have a budget and people come out and they testify on it. But interestingly, Kennedy didn't really talk a lot about the budget. He didn't comment specifically on 340B. A lot of the questioning was focused, again, on his past comments on vaccinations, some recent firings at HHS that were pretty controversial, and Medicaid cuts, which are another hot topic on Capitol Hill. But notably, U.S. Rep. Diana Harshbarger of Tennessee, she's a Republican, a pharmacist, and a member of the NC Health Subcommittee. She brought up 340B during her 5 minutes of questioning with Secretary Kennedy. So specifically, she floated the potential for renegotiated quote-unquote 340B contracts. And her comments here drew a little bit of criticism from some 340B advocates who suggested that she misunderstands the program's structure. So this comment came about in the context of Harshbarger was asking Kennedy about his support for PBM reform. It's been an issue that's been kicking around on Capitol Hill for a couple of years now, was included in a year-end spending bill and then pulled at the last minute, 2014. And it was included in the House-passed version of the reconciliation budget known as the, quote, Big Beautiful Bill. The Senate has done some tinkering there, and it's unclear whether those PBM provisions are going to make it into the final version. And so Kennedy expressed support for that, for addressing PBMs. He also brought up negotiations over President Donald Trump's most favored nation executive order and saying that the talks with drug makers are happening now. And it was in response to that Rep. Harshbarger mentioned renegotiating 340B contracts. It's unclear exactly what she meant there. Her office did not respond to our request for clarification, but just wanted to note that because it was a pretty interesting thing given Harshbarger's background on 340B policy. She's one of the sponsors of the 340B Access Act, which is a bill that was crafted with input from this coalition that pharma and the National Association of Community Health Centers formed to figure out their agreements for best reforms for 340B. That bill came out last May. It was super controversial, and it didn't really see a lot of movement on Capitol Hill. And there is an expectation that the bill will be reintroduced in the new Congress with Harshbarger again as a sponsor. So we haven't seen it yet, and it's unclear exactly what she could be pursuing there, but it gives us a little bit of insight. And then again, just noting that Kennedy spent a lot of time talking about the MFN negotiations. So again, President Trump in May issued an executive order that called on drug makers to voluntarily align U.S. prices for single-source brand name drugs with the lowest prices available in other countries, developed countries. It's unclear exactly how they're going to do this because the White House has limited power to influence the price of prescription drugs in other countries, and congressional action would be required to directly lower U.S. drug prices. Kennedy was asked about this, and he said, quote, the administration has a number of sticks and a number of carrots, but he didn't provide specific details as to what those carrots and sticks are. He also briefly noted that talks with drug makers selected for the second round of Medicare drug price negotiations under the IRA appear to be on pace to meet the November 1st deadline. And that, of course, is for the prices that will take effect in January 2027. And so that's kind of what we got out of Kennedy. It's sort of our latest, update on where things stand coming out of the administration for drug prices. But it's not the only issue that gained some traction in the past week. Will, you wrote a little bit about another executive order on drug prices that saw some action. So if you want to give us a little update there, that'd be great.
Yeah, definitely. So in April, Trump issued an executive order that included a number of things about drug pricing, but one provision in particular that has pretty direct 340B implications, which was essentially directing HHS to ensure that community health centers are passing all 340B savings on insulin and EpiPen products directly to certain low-income patients. So sort of implementing this new requirement. So this is actually pretty similar to an executive order that Trump issued toward the very end of his first administration back in 2020. That executive order faced pretty strong criticism from community health centers who argued that it would create a pretty significant administrative burden without really directly helping patients too much. And the Biden administration actually ultimately rescinded the rule stemming from that order from taking effect. So that 2020 version never actually took effect. But, now we're in April 2025, and a pretty similar version of this came out. So just earlier this week, HRSA actually sort of formalized how it's going to go about implementing this, and it is through new grant requirements. So essentially, health centers have to comply with this in order to continually have access to their grant funding. So it specifically applies to federally qualified health centers, or FQHCs, does not apply to FQHC lookalikes. And it's a little different from the 2020 order for a couple of reasons. The first one is that this new requirement from HRSA defines low-income patients as patients with an income below 200% of the federal poverty line. So the 2021 defined it as under 350% of the federal poverty line. So this is pretty significant because community health centers already are required to provide a sliding fee discount to patients with incomes below 200% of the federal poverty line. So they already have screening processes in place to sort of determine which patients are eligible, which they would not have had for the 350% threshold. That said, this order does implement additional requirements. Health centers have to not only determine if the patients are under 200% of the federal poverty line, but also whether or not they are uninsured or have high deductibles or high cost sharing. So, anytime you're actually doing additional screening, there is some administrative cost associated with that. So that is something that certainly FQHCs will be grappling with and are opposed to in the sense that it, creates more burdens for them. The other pretty notable difference is that the 340B price for insulin is generally a lot higher than it was in 2020. So that means that, this idea of passing savings directly to patients may not have quite as much of an impact as it would have in 2020. And the reason really stems from a number of things related to the Medicaid drug rebate program, but most notably the removal of the AMP cap, which is a pretty technical thing, but it was part of the took effect in 2024 and basically is leading to there being fewer penny-priced insulins and generally higher 340B costs there. So that's sort of the other main difference there.
Thanks, Will. That's really interesting. So this brings us to the states. We now have 20 states that have passed contract pharmacy access law, and another one that's on the brink of enacting one. Now, this is being recorded on June 26th, so very well could have that 21st one by the time this airs. And I just want to note that this is due in part to the recent actions in New England states, which is my home turf. So it's always interesting to see New England added to our map here. Will, do you want to just break down some of the latest of what we've seen?
Yes. So number 20 of the 20 states that now have laws prohibiting drug makers from placing contract pharmacy restrictions, that would be Maine. So as part of a larger budget bill, the Maine governor recently signed a bill that would, again, prohibit drug maker contract pharmacy restrictions and also add some new hospital reporting requirements. So Maine was actually one of the first states back in 2023 to pass a law requiring hospitals to report more information about their 340B program. It was pretty narrow in scope, basically just asking hospitals to, or requiring hospitals to report their total 340B savings and a description of how they use those savings to benefit their communities. So that law has already been in effect. And this new law that just passed that has the contract pharmacy protections added some new requirements there that require Maine hospitals to break down their total acquisition costs by payer type, report some more specific information about contract pharmacy use and some other areas. So that sort of makes Maine's reporting law for hospitals a little more expansive and more in line with sort of what we've been seeing in several other states. So that's sort of the latest there. And I know that Maine was number 20, but we potentially could have number 21 pretty soon. Shannon, do you want to tell us about that?
Yeah, so that state is Rhode Island. So if you remember last year, Rhode Island had fallen just short of passing a contract pharmacy access law at the end of session. This year, though, they were able to get it over the line in the final day of the legislative session on June 20th. Both the Senate and the House versions of this bill passed and have been sent to the governor's office. So Governor Daniel McKee has until July 3rd to take action on the bill, or they will become law without his signature. Now, just a note here, only one of the bills has to be signed into law. Rhode Island just has a tradition of sending bills sponsored by both chamber. So that's just a little interesting tidbit about Rhode Island there. So specifically, this bill is a contract pharmacy access bill, but it also includes provider reporting requirements and protections against alleged pharmacy benefit manager and insured discriminatory practices. So it, like Maine and some of these other more recent states to pass bills, has included the hospital reporting provisions in there. If enacted, it would prohibit health insurers, PBMs, drug manufacturers, or other third-party payers from discriminating against any 340B entity participating in a drug discount program as of October 1st. The bills also include a provision that would specifically prohibit drug makers from restricting the acquisition or delivery of 340B drugs to contract pharmacies. Covered entities must also submit a report to the governor's office, legislative leaders, and other state officials by April 1st each year, detailing its participation in the 340B program during the prior year. And Rhode Island also included similar language in the state budget that also passed at the end of session. The Speaker's office told us that that portion of the budget was included to ensure that 340B is applicable to the state's Medicaid program. And so that is just sort of the final portion there. So we are keeping our eyes on Rhode Island. And again, by the time this airs, who knows, they could be the 21st state. So Will, want to tell us a little bit more about some of the other state level actions we've seen since our last podcast?
Yeah, so zooming out a little bit in terms of what we've been seeing overall, over the past 2 years, there's just been a huge surge in legislative activity, but how that's shaped out has looked a little different this year than it did last year. So in 2024, 8 different states passed laws prohibiting drug maker 340B contract pharmacy restrictions. All of those were, basically just contract pharmacy protections. There were no new provider reporting laws passed, although there were 3 from 2023 already in the books. But in 2025, as there have been even more states enacting contract pharmacy access laws, we've increasingly seen a lot of states enacting both contract pharmacy protections and provider reporting elements as part of the same bill. And so, that's not only the case in Maine, but we also saw that in Oregon and Vermont and Colorado and Hawaii. So that's been a pretty important trend that we've been following here and seeing, it increasingly seems like when state legislators are looking at crafting or enacting 340B legislation, they're looking both at contract pharmacy protections and requiring a little more reporting from providers as well. So that's another thing that we're certainly very closely monitoring. And, if Rhode Island does end up passing the law, then that would be yet another law that sort of combines both of those provisions. So very interesting stuff there, as always.
Yeah, definitely. So that brings us to the end of today's episode. We'll continue to keep an eye on all things 340B related, and we'll be back in 2 weeks with a new episode. Of course, we will report on anything that happens in the meantime on our website. So please follow along with our twice weekly newsletters, which come out each Tuesday and Thursday. We'll also probably be sending some news alerts, especially if Rhode Island takes action before then. So yeah, keep listening and keep subscribing and following along.
Just as a final quick reminder, if you are not subscribed to 340B Report, first-time subscribers can take advantage of our 25% discount by going to 340breport.com, clicking on the subscribe button, and using our special discount code podcast25. So I definitely encourage our listeners to do that if you are not subscribed.